Ladies and gentlemen, dear friends, good morning. First of all, let me thank Professor Ines Schout and the organizing committee of the AASD Conference 2021 for inviting me to be with you once again. The topic that I have chosen to deliver today is diabetes and value-based healthcare. What I will try to provide is some key messages in regard to this topic. Why value-based healthcare? What is value-based healthcare? What is necessary to implement value-based healthcare? How to implement based healthcare in diabetes? So let's start from the consideration that there is the need to revise the delivery of care worldwide due to a number of factors. First of all, the fact that the expenditure on healthcare is growing at an unsustainable rate, and this is true everywhere in the world. Another point is that there is a lack of outcome measurement that represent what truly matters most to patients, is a global barrier to driving healthcare improvement. There are problems which produce some relevant drawbacks. There is a paucity of outcomes data beyond basic mortality measure, which produce a lack of information for patients and providers on where what we do works, especially with a disease with diabetes, where the effect of our activity are on a long term. Where available, outcomes are hard to compare and not standardized. This slow pace of change and inability to learn from others. Outcomes are often not patient-focused, so that the success is not defined from patient perspective. There is a large focus on process measure based on the assumption that changing processes improve outcome for the patient, but this is not necessarily true. So there's been a number of considerations, and there is now this proposal for this new model, which is the value-based healthcare, which is helping shift focus from volume of services to value created for patient. And this has been elaborated by Professor Porter of the Harvard Business School. So the fundamental goal and purpose of healthcare is to improve value for patients, so that in the formula for the evaluation of value, health outcomes that matter to patients are divided by the cost of delivering of these outcomes, and this produces the value. Value is the only goal that can unite the interest of all systems participants. Value is created in caring for a patient's medical condition over the full cycle of care. And we have to consider that the most powerful single lever for reducing cost and improving value is improving outcomes. Then we need data which are reported by the patient. And these data, they complement the physical, the physiological, and biochemical data in order to improve patient of care. It's not substituting, just complement. And so the patient-reported outcome, PRO, is any report of the status of a patient health condition that comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. PROMS, the patient-reported outcome measure, so this outcome need to be measured. And this type of measurement is any instrument, scale, or single item measure used to assess the PRO concept as perceived by the patient, obtained by directly asking the patient to self-report. Generally includes clearly defined methods and instruction for administration of responding, a standard format for data collection, and well-documented methods for scoring, analysis, and interpretation of results in the target patient population. PROMs support patients to raise issues with clinicians. PROMs completion prompts patients to engage in self-reflection, enables them to identify what is important to them, and develop a deeper understanding of how their condition has affected their life. On the other hand, PROMs raise clinician awareness of patient problems. Systematic and comprehensive assessment of patient perception of their symptom, functioning, or health-related quality of life. Alert clinicians to patient problems. Prompt discussion on subsequent care processes. So there is the need to structure, the way to deliver, value-based healthcare. And this has been the target and the mission of an independent non-profit organization, ICHOM, the International Consortium for Health Outcome Measurement, which was funded in 2012 by the collaboration between the Institutes for Strategy and Competitiveness of the Harvard Business School, the Boston Consulting Center, and the Karolinska Institute. So the mission of ICHOM is to unlock the potential of value-based healthcare by defining global standard sets of outcome measures that matter most to patients across a wide range of medical conditions and driving the adoption and reporting of these measures worldwide. ICHOM standard sets provide a universal approach to data collection. They are based on the understanding of the key stakeholders, professional and expert, and patient representative, and the methodology and for the development of the standard set are related to the fact that outcomes are defined around medical condition, not around specialties or the procedure. Some standard sets are a minimum set focused on outcomes that matter most to patients. Patients are directly involved in defining every standard set. Patient-reported outcomes are part of every standard set and include functional status, symptoms, burden, and health-related quality of life. A minimum set of initial condition risk factors is included to facilitate a meaningful comparison. Time points and sources of data collection are clearly defined to ensure compatibility of results. So there is a journey toward the value-based healthcare in diabetes, which require a strategic agenda, starting from the definition of standards to the benchmarking on outcomes and to establish outcome transparency. So that's require to measure the outcomes, to collaborate, to improve value, and to develop value-based payment models. But the first step is the definition of standards. And the standard set for adult type 1 and type 2 diabetes has been developed through an ICHOM initiative by an international diverse group of professionals and patients, which reunite in a working group of 28 participants with the representing 19 countries and patients across 3 continents. The group was chaired by the Hub for International Health Research and the University of Bologna. So the ICHOM standard set covers adults with type 1 and type 2 diabetes, pediatric and neonatal population aged below 18 years, gestational diabetes and secondary diabetes are excluded because they have specific conditions that require attention separately. The management approach is regarding the education and lifestyle, the pharmacological and psychosocial care. The stage of the disease that has been taken into consideration is uncomplicated diabetes, complicated diabetes, and diabetes with comorbid conditions. The standard set for diabetes contains 3 categories of data: patient-reported outcome and results of care that are assessed by the patient and reported by the patient. As an example, well-being and stress. provider-reported outcomes and results of care that are assessed by and reported by the healthcare provider. As an example, traditional measures like glycated hemoglobin. Case-mix variables, variables that affect how well a patient may respond to treatment, but can be changed or very difficult to change as part of the treatment. For sure, age cannot be changed, and smoking status is very difficult to be changed. So this has produced a standard set divided in 6 parts, which refer to the acute events: diabetic ketoacidosis, hyperglycemic, hyperosmolar syndrome, and hypoglycemia; chronic complication, micro and macrovascular complication, nervous system complication, the treatment complication. Then survival with the vital status, if a patient is alive or not. The health service, financial barriers to treatment, and healthcare utilization. And the diabetes control with glycemic control, diabetes control with the glycemic control with a number of items. And finally, the patient-reported outcomes, psychological well-being, diabetes distress, and depression. The follow-up algorithm for each of the items has been considered, starting from baseline to 6 months, 12 months, 18 months, 2 years, and so forth. So each of the items has its own algorithm for follow-up. This standard set and the procedure, the methodology, and the outcome has been published on diabetic medicine by all the members of the group. And they include the description of all the items with all the measures, items, measure, or indicators, how you prefer, which is with the definition, the supporting information, the timing of assessment, and the data source. They can be the clinician, the healthcare provider, or the person with diabetes. So this is, available. So based on this instrument, is it possible to build in a diabetes value-based healthcare plan through the ICHOM standard set? But this is not a simple, activity. It's quite complex. It's required to recruit pilot sites, to run pilot implementation, to review data dictionary in view of lessons learned, scale up implementation and data recording, and benchmark and use data for quality improvement of value-based healthcare. And it is to be considered that there are a number of factors which have an impact on the implementation of PROMs at different stages of implementation pathway. Definitely, there is the need for a careful pre-implementation planning. There is the need to adopt standardized processes which help streamline the implementation. Of course, there is the need that the leaders of your organization, they support and promote the adoption of this activity. And there is the need for a collaboration, strong collaboration of all the members of the several institutional groups which participate in the project. But then we have to consider that the implementation of PROMs may be supported by facilitating factors, choosing PROMs that clinicians feel are relevant to their patients, clinicians receiving feedback on their patient scores, organization providing sufficient training and support to staff on using PROMs. But we need to be aware that there are also barriers. The clinician believing that they do not have the capacity to use them, clinician perceiving their practice is being judged on changes in PROM scores, organization not having the resources to utilize PROMs, organization not incorporating PROMs into existing workflow. However, this once we adopted, we can consider that the implementation of transparent, high-quality outcomes data trigger quality circles, which that then produce a value by considering the feedback and learning, the analysis of the variations, the identification of current best practices, and the evaluation of the evolution and changes of the behavior. So this is producing a value, but this value as a value, if it is a value for all the key stakeholders, and through value-based medicine, there is an advantage for patients, for clinicians, for hospital, for payers, and for the life science. So we can consider, I do hope that this very fast evaluation of the value-based healthcare can somehow be helpful, and I do hope that next year we can reconvene in order to evaluate whether initiative has been put in place and to evaluate their results. Thank you for your attention.